Good morning, Hector.
Top of the morning, Dr. Alfonso.
Good morning. If this is the first time you're meeting me, hello, I am Dr. Michelle Alfonso. Now, if you have met me before, or you have watched some of our videos, or you're wondering where's Dr. Larry Saylor, well, he's not joining us today, but with Hector's help, I am holding down the fort. So today's topic is based off of two patients that we've recently seen in the office. And that's typically the cases for the blogs and the presentations that we do. They're inspired by real things that happen, real patient experiences, real discussions from the days or weeks prior to us actually doing these recordings. They give us an opportunity to shed some light on things that happen in everyday dentistry in our daily practice. And it keeps our patients very well informed. So the stories from this past week that inspired this topic are two individual patients. Their stories are similar, yet they're so different. And what makes them similar is they both have a condition in their teeth. One tooth has dental resorption. That's an important dental term that we've actually done a video on in the past. And because we've done a video on it in the past and we went in depth in terms of what it is, the types, and how to treat it, I encourage you for that in-depth look, please go to our previous video. But for the purpose of today, just a brief example or a brief description of what dental resorption is. It's a process going on inside the tooth where the tooth is degrading slowly, and it's caused by the cells either within or around the tooth. It's actually an inflammatory process. So those are inflammatory cells kind of eating away at that tooth. And typically, it's a painless process and it's a silent process. And one of the ways we actually find it is going to be on your x-rays. So that emphasizes the importance of the regular dental exam and the annual x-rays, because these silent lesions, sometimes we do not find them until we take an x-ray. And what they look like, they're going to be dark areas in the tooth, kind of like a gap, something that shouldn't be there. It could be in the crown of the tooth or it could be in the root of the tooth. And typically, they start off something small. So back to the story that inspired this whole topic. So our two patients. One of them came in for their hygiene visits recently, and she has a lesion or a resorption area that we noted years ago. So years ago, we took an x-ray at the hygiene visit, so she stays on top of those x-rays. And we saw that little area. We pointed it out and we asked her, well, do you have any symptoms? She said no. So it's asymptomatic and relatively small. So we said, okay, this is something we can monitor. So watching that tooth and monitoring it over the years means taking x-rays, measuring the area of darkness, seeing if it's growing, and keeping an eye out for any changes or symptoms. And year after year, that's what we did. And at her last visit, just like before, the same holds true. The tooth is pretty stable and it hasn't grown and it hasn't changed. And that's really, really great. In the scenario that she has resorption, she has that inflammatory process. But in lack of a better word, it's kind of behaving itself. Now, the other part of this story are our other patient. Her case of resorption started off small, just like our first example, but we found hers about a year ago. So about a year ago, we noted it. It was asymptomatic, and it was small, and it didn't seem to be something going into the nerve or causing extensive problems. And so we made the clinical decision of saying, okay, this is something we monitor. And monitoring means coming back in 6 months to a year and taking another x-ray. Well, for her case, it was within months, not years, but just months, that small lesion expanded, and it was kind of aggressive. I kind of compare it to a wildfire just spreading through that tooth. So you can see that the lesion got deeper into the tooth, and it causes her case of resorption to be more complex, needing more advanced treatment. So you can see how similar they were at the beginning. Small areas that we've noted of resorption, but how they behaved are completely different. And that's the heart of today's topic. When we tell patients you have resorption and we want to monitor it, a lot of the times they ask, well, if we're going to monitor it for how long, and when do we do something about it? Now, the idea of monitoring resorption or going in and treating it is one of the challenging questions that dentists and patients face as we make decisions together. And the reason why is, case in point, these two patients, resorption isn't one size fits all. It can vary in terms of how it progresses from patient to patient. And that can be frustrating. You know, if you have a tooth that we say we're going to monitor and within months that tooth really becomes something drastic and requiring more complex treatment. The best way to really handle resorption in terms of guidelines, things that we can do to monitor the tooth and decide what path we need to take, as I've said, is regular x-rays and exams. So the regular x-rays and exams, if we find an area of resorption, could be every 6 months taking an x-ray of that tooth. And then if we see that it's not really changing and it seems to be on the stable side of things, then we can graduate to taking x-rays once a year. Now, if we see the opposite and we do see it changing a little bit more drastically, that's where more frequent checkups will be needed, and maybe some earlier intervention is needed. So I like to think of this in terms of scenarios, because to set an expectation for when you have resorption, the 3 scenarios that you can have is, first, we find it and it's pretty stable, where we have regular checkups and it doesn't seem to be changing. And importantly, it's not symptomatic. That's another one of those genuine rules or general ideas that we want to present, that, okay, we're checking on an x-ray, but at the same time, the patient should be telling us if they have any symptoms on that tooth, because it can become painful. It can have some sensitivity to chewing or to cold. And it can have some signs that the gums are inflamed or there's some sort of swelling going on around that tooth. So again, if you're in that first scenario and you don't have any of those symptoms and we're able to monitor the tooth, that's really the best case scenario, where we would say that tooth it's a guarded prognosis because resorption is unpredictable, but it's a good scenario where we can hold on to that tooth for a while, which is always our goal in terms of trying to hold on to teeth that have resorption, until we see that they have changed, and then we do shift gears, is what we actually say in the office. So second scenario that you might fall into, we find resorption, but we know on the x-ray 6 months or a year later, it's changed a little bit. It is growing. And if you think about it like a little black hole within the tooth, where it's growing is what we're watching out for. If it's getting into the nerve of the tooth, or starting to encroach into the structures such as where the roots split, which is called the furcation. And so we don't want this resorption to compromise the nerve, and we don't want this resorption to compromise the structural stability of the tooth. So that's where we may say, hey, it's time to intervene and do something with this tooth. The third scenario, like our patient that we recently saw, where the resorption has expanded rapidly. And even though we follow the regular checkups of seeing every 6 months and then graduating to a year, in her case, within the 6 months, the change was so drastic that immediate intervention was required. And that's where you fall into what can be the frustrating part about this. If you fall into that category that your resorption, this biological process of inflammation, just kind of goes haywire, then you're stuck at a point where maybe you need more advanced treatment. And sometimes in the office, what we say, we call it hero dentistry or hero-dontics. And that's really doing everything we can to save that tooth and hold on to it. But the prognosis for a tooth like that isn't guarded. Sometimes it's more like a poor prognosis. The predictability of a tooth like that, where you're looking at a big hole through the tooth, and these are 2D images. If you see what a 3D image of this tooth looks like, you can see how extensive it is. And what makes that difficult to treat is, if you have such a big hole in the tooth, but how do you seal it again? How do you get a structure that's sustainable, that keeps that tooth healthy, that allows you to keep functioning and chewing on that tooth as well? So those are those 3 categories. And again, knowing how unpredictable resorption can be, kind of seeing where you fall with those early x-rays, and trying to be on top of it, so if something happens, we can treat it earlier than later. So we kind of talked about what to look out for, which is why we take those x-rays. We're looking for the changes. We're looking for symptoms. Now let's say you fall into the category of, all right, it's time to intervene, it's time to do something. What exactly needs to be done? The goal is to take the inflammatory tissue and get it out of there, clean out the problem. And the person that will actually go in and do that is typically going to be the endodontist. So this is where I want to emphasize the importance of having a really, really good team of specialists with your general dentist to tackle these kinds of somewhat challenging cases. You know, if your resorption is one of those wildfires that is spreading, it can be challenging for the endodontist to go in and clean all that up and again make that seal. So working with a specialist that not only has the skills, but they have the materials needed to be able to seal and provide the best treatment for that tooth to try to get some longevity, to try to hold on to it, is very, very important. So your dentist is, well, we're the front lines. We're going to be the early detection. If we start seeing those changes to the point where we're saying, okay, it's time to see the endodontist. But for us to know that our specialist, the person that we are trusting and putting you in the hands of, are using these modern dental materials that really give the tooth the best chance to stay stable, be sealed, and prevent reoccurrence of these types of things, is such a benefit for us, which is why when we say, you know, we want to send you here, it's because we have that relationship and we know that we're sending you to a very skilled and highly expertise, or endodontist with great expertise. So the endodontist goes in and cleans that up. They use their microscope. And one of the things that we kind of talked a little bit about is the CBCT. They might take a CBCT to see the extent of how large your resorption is. At the end, once everything's been cleaned up in the inside of the tooth, to add some strength to try to prevent from having any complications, we typically recommend that that tooth could get a crown. And then from there, you need regular maintenance. You know, come in for your regular dental exams and checkups to make sure that tooth is doing well, especially when it was a symptomatic tooth that was causing pain. We want to know that after all that bad inflammatory tissue has been cleaned out, that that tooth has calmed down. And when we see you for those regular checkups, it's almost like a victory where we're like, okay, we had this situation, we're kind of going into battle fighting this unpredictable resorption, but at the end, if we can save that tooth and prolong the life of that tooth, that is a victory. That is great, and that's what we try to do in these cases. Regular monitoring to make sure that we're keeping an eye on how it's doing, and then catching it early to be able to give the best chance to hold on to the tooth is why we're talking about it today. And if you fall into that category of, oh man, this is so frustrating, we just saw this 6 months ago and now it's a wildfire, it's because this is an unpredictable type of scenario. It's a biological process. So please, you are not a type of person that should be skipping on your x-rays if you have resorption. Regular checkups is really how we're going to stay on top of it and try to catch it in that stage. But it's possible that we get to that point of, you know, this tooth is not predictable and it might be needing an alternative treatment, which is taking it out and replacing it with an implant. And that was the case for our last patient whose resorption really extended so quickly within months. And that is challenging as a dentist, but that is the challenge of resorption. What if I told you there's a part of your body that can actually improve as you age? Your vision, your joints, your skin, they tend to decline as you age. But your teeth can actually get better.
Hi, I'm Dr. Larry Saylor.
And I'm Dr. Michelle Afonso.
At our practice, we developed a proven system designed to strengthen your dental health as you age, not just maintain it. By identifying your unique dental risk, we create a focused, personalized strategy to not only prevent problems, but to help your smile look better and feel healthier over time. The result, fewer emergencies, a higher quality of life, and a smile that keeps getting better.
Year after year. If you're curious about how it works, reach out to our office and start your journey for a healthy, beautiful smile.